Good afternoon, everyone, and thank you for joining us. My name is Kay Matthews. I'm the founder and executive director of the Shades of Blue Project, where our mission is focused on Black maternal mental health through a reproductive justice lens. And I will be your moderator for today's conversation. We will start with opening remarks from Representative Robin Kelly of the Congressional Black Caucus Health Brain Trust. It's technology, y'all. Give it a minute.
Good afternoon. This is Congresswoman Robin Kelly, Chair of the Congressional Black Caucus Health Brain Trust and author of the Mamas Act. Before we begin, let me start by thanking Kay Matthews and the Shades of Blue Project for hosting today's conversation. I'd also like to thank the co-hosting organizations, Black Mamas Matter Alliance, ACOG, NAMI, 2020 Mom, and the American Psychological Association. We all know the sad facts of the racial disparities present in America's maternal mortality crisis. Nationwide, African American mothers die at 3 to 4 times the rate of white mothers, but in some states, like my own home state of Illinois, the disparity climbs to 6 times. For Native mothers in Washington, the disparity is 8 times. Now, that's just deaths. That's not morbidity or mothers who are injured. And that number most certainly doesn't include moms who face postpartum mental health challenges alone. My background is as a trained counselor. Today, I get to continue that work in Congress, fighting for mental health resources for our young people, new moms, veterans, and our first responders. To me, the most important thing we can do to support the mental health of new moms is expand Medicaid. Medicaid, which covers more than half of births, expire for new moms just 60 days after giving birth. But we know that most moms will have at least one mental or physical complication after those 60 days. They should be able to see their doctor, period. My bill, the Mamas Act, will require states to expand Medicaid for new moms to the entire 1 year postpartum period. Unfortunately, I'm still struggling to get a GOP co-sponsor for this bill. But because we cannot allow the perfect to be the enemy of progress, I've developed a compromise with my GOP colleagues called the Helping Moms Act. The Helping Moms Act would allow states to expand Medicaid without a waiver and incentivize it with a federal dollar match. It's not perfect, but it can pass, and it's a huge step forward. Right now, my state is waiting to hear if its waiver is approved. We are ready to expand, but can't without approval. The Helping Moms Act changes that. But I need your help to pass it. After you leave today, take the next step tomorrow and become an advocate. Call your member of Congress, or even better, write an op-ed asking them to co-sponsor. We know what we need to do to provide better physical and mental health services to pregnant women and new moms. Let's help my GOP colleagues find the political will. Thank you again.
Thank you, Representative Robin Kelly and your team for providing our opening remarks. So joining us today for this candid conversation around bridging the gaps in maternal mental health for Black mothers is Professor Kim Baker with UT School of Public Health, Interim Executive Director Angela Aina with Black Mamas Matter Alliance, Professor Karen Tabb with the University of Illinois School of Social Work, Dr. Saida Pepera, founder of Diversity Uplifts, Inc., and Dr. Joya Crear-Perrier, Executive Director of National Birth Equity Collaborative, who will be joining us later in the conversation. So as we navigate through this conversation, I'll be giving each of my colleagues an opportunity to share in their work how they feel we can work together to bridge the gaps that currently exist in maternal mental health for Black mothers, and how we can help the collective work that is being done through the Momnibus move legislation forward. So we're going to begin with Professor Kim Baker. Professor Baker, how do you feel we can work together to bridge the gaps that currently exist in maternal mental health for Black mothers?
Thank you, Kay, and thank you for the panelists for being here as well. A couple of things, I want to kind of start this off with how I started off in public health. And the first lessons that I learned as a student years ago was that one of the most persistent indicators of a nation's health was the health of a woman. And so we know now that the US is not well, and it will remain that way until strategies are implemented to improve not only the maternal health, but the maternal mental health of Black women. So my work involves ensuring reproductive health access, particularly in Texas, is granted for every woman that needs it through the Own Every Piece campaign. We talk about better birth control access, more dignified care and treatment for some of the most sensitive and critical issues. But we must acknowledge that access and care starts long before women become pregnant. And oftentimes, it's really how young women are treated when they're navigating their reproductive and sexual health services. Mm. The lasting trauma from this, and what we can say, a lot of it racist ideology and practices that are current in our policies and the way we treat young Black women in particular, is a big issue. It's a big problem. Furthermore, we know that women who experience an unintended pregnancy are more at risk for maternal depression in the postpartum period. And so the Helping Moms Act, or extending Medicaid for a year after well into the 4th trimester, will not only allow the much needed support for mental health services, but also allow women to make the necessary decisions about family planning if they so desire, and not feel rushed, not feel coerced into making decisions because they may not have care in a matter of weeks.
Agreed. So, I like how you mentioned the 4th trimester. I just want to say that that's so important that we start to use that language, so then we can truly identify what the postpartum period does matter, right? We think about 1st, 2nd, and 3rd trimester, and we're like, okay, the baby's here. So if we start to implement the language around the 4th trimester, that makes what we're talking about today and just the whole spectrum of looking at maternal mental health a real thing, right?
Yes, that is not separate. It is not separate. It is not or an afterthought. It is all together, and we have to look at it in that way.
Agreed, definitely. And so I'm going to pass the question over to Angela and get your thoughts around what do you feel and how you feel the work that we can do together can bridge the gaps that currently exist in maternal mental health for Black mamas.
Absolutely. And probably are going to take us a little bit of time because, we got a lot to say in this arena. So first and foremost, thank you. Genuinely thank you for the work that you do, Kay. Thank you for lifting this up. Thank you for even lifting this up as one of the core tenets of the work that we do, right, at the Black Mamas Matter Alliance. So I want to say thank you, Kay Matthews and the Shades of Blue Project, for inviting us to contribute to this congressional briefing to address and to talk about Black maternal mental health. So here at the Black Mamas Matter Alliance, we are a national network of Black women-led organizations and multidisciplinary professionals who work to ensure that all Black mamas have the rights, respect, and resources to thrive before, during, and after pregnancy. And we honor the work and historical contributions of Black women's leadership in particular within their communities, and values the needs to amplify this work on a national scale. And really, this is why we don't have any chapters as part of the Alliance. The Alliance is composed of existing organizations and individuals whose work is deeply rooted in reproductive justice, birth justice, and the human rights framework. And we use the phrase Black mamas in particular to represent the full diversity of our lived experience that includes birthing persons, that's cisgender Black women, trans folks, and gender nonconforming birthing individuals, and all people of African descent across the diaspora, because we know that we also need to be uplifting the experiences of Afro-Caribbean, Black, and African immigrants in the work that we do, and to also support and uplift the presence of those people that we call Black mamas who may not have given birth, but they mother our families and communities. So we stand in solidarity with them. And with this issue, or these issues in particular, we know that it has continued to be identified, such as a lack of medical care, delayed or non-response to cries for help due to complications during pregnancy, structural racism and institutional racism, and social determinants affecting the health and the birth experience overall. You know, for us, Black maternal health inequity is significantly a human rights crisis in this country. And so the conversation of Black maternal mental health may seem new to some folks, but it has been historically present in our community. A great example is the work of Kay Matthews. Statistically, 1 in 7 women experience postpartum depression. And we know this through the data that has been collected through the maternal mortality review committees across the country, have found that mental health related issues are contributing factors to pregnancy related deaths. These statistics compound the issue that Black women are 3 to 4 times more likely to die from childbirth as compared to white women. And the COVID-19 pandemic and response from the medical facility policies that isolate birthing people continues to stress those birthing persons during pregnancy and the postpartum period. And so the Momnibus Act of 2020 presented 9 bills to address Black maternal health through models of care, research, technology, and funding across all demographics of Black women. Gratefully, 4 out of the 9 bills directly create a measure to address the mental health of Black mothers in particular. And these are Title III, Protecting Moms Who Served, Title VI, Moms Matter, and Matter with an M-A-T-T-E-R, Title VII, Justice for Incarcerated Moms, Title VIII, Tech to Save Moms, to create a task force, grant opportunities, research and outreach to prioritize mental health services in different models of care. And so the Momnibus Act is an opportunity for the country in particular to address the needs of Black women and birthing people in succeeding in our mental health, not only as mothers and caregivers, but as individuals as well. So again, we encourage our policy leaders to prioritize passing these bills and working with Black-led organizations and movements that are most impacted by these issues. So again, thank you, Kay, thank you everyone so much, and especially to the Shades of Blue Project and this very important work around Black maternal mental health, and all the representatives present and our wonderful panelists and those across the country that are really working to center and work on Black maternal mental health. Thank you.
Thank you so much, Angela. I truly appreciate you and all of those that are associated with Black Mamas Matter Alliance. Of course, as a kindred partner, one would think I'm a little biased. I just may be, but I'm just saying the work that's being done over there is very important. And it's important for others to see us work together, right? There's a Black Maternal Health Week. That's for a reason. The same why there's a Black Maternal Mental Health Week. It's for a reason. These two things go together. And so hopefully The bigger picture is that none of these weeks need to exist, right? They exist because there's an issue that does not have a lot of attention. So this is how we uplift it, and this is how we bring it to the forefront. So there's no separation here. We all work together because we are all in this thing for the common reason. We truly are. So again, I appreciate Black Mamas Matter Alliance and all that goes into the work in this space. I wanted to take it back over to Professor Baker, as she has some additional comments before we move forward to Professor Tab.
Yeah, no, I just wanted to add and be very clear about what needs to happen here, right?
Yes, this is all about action, so please.
Right, to ensure that not only that we're providing continuous access for women, but we're also thinking about using this opportunity in the pandemic. 5 million people have lost health insurance, right? And so we're at a critical point for action. And so we need to use this point to try to transform things that should have been transformed already. And so what does that mean when we think about mental health in particular and the vast amount of harm that has already been done? And I'm glad the other panelists brought up the social determinants of health, because when we think about power being the most impactful determinant and the least understood determinant. So what does it look like to shift power in our communities? What would it look like to transform our research, our care delivery systems, the training in our schools of public health, nursing, social work, our schools of medicine? This is the long term. This is a long game. This is a long game. So we have to ask these questions. I know we're going to have the Q&A, but what does that look like for us?
Yeah, no, I appreciate you bringing it up now, so it gets folks thinking, and they can put those questions that they want us to answer in the chat box. So go ahead and do that now. So again, thank you, Angela, and thank you, Dr. Baker. I'm going to turn it over to you, Professor Tab, to get your thoughts. You and I met. I'm going to make everything personal today. You and I met at a convening together for a presentation at ACOG, and it was like we've been old friends ever since. That's what happens when one does not look at you through a lens where they don't trust you. They value what it is you bring to the table and what that looks like. So it was an automatic connection, so much so that we sat next to each other and exchanged notes on how we would close out the event. She went before me, and then I brought it all full circle. So we've been stuck together like glue ever since, and I appreciate you joining us today in this conversation. So when we think about what can be done to bridge the gaps that currently exist when we're talking about Black maternal mental health, what are your thoughts around that? And of course, we're all talking action today. So what do you feel like we could be doing moving forward?
Well, I want to say too, the reason why you and I just vibe so well together is a personal connection to the work, right?
Yeah.
A very personal connection to the work. And some days more than others, I become emotional on the personal aspect of the work. But we mentioned maternal review committees, and that's kind of where I want to pivot back. That is an action step, right? Untangling how we're actually documenting maternal mental health and how it plays a contributing role to maternal mortality as one of those morbidity factors. So I'm going to go back to the death and how do we prevent that and weigh in. I am one of the original authors on the global burden of disease study that blew the lid off of existing numbers. We didn't come up with that 7 deaths per 100,000. We got 17 on our first paper and knew that was not good. And we came back and revisited the question again with even more data to add to our estimates and found that 26 women per 100,000 were dying in this country. And we know those disparities are worse for our racial and ethnic minority women, in particular Black women. And thank you for that encompassing definition of what Black in this country is. And our Native American, Alaskan Native women are disproportionately experiencing that burden. maternal review committees they're focused on those severe maternal morbidities, sepsis, hemorrhage, all horrific things. But if we start breaking down the numbers, we'll notice that 1 in 4 women are dying related to complications from mental health, which hurts me because it's easy. It's all hard, but it's easy to prevent, as hard as it is, if we're asking early. And then of those 25% of women who are affected by maternal mental health, 1 in 6 are losing their lives to suicide. So just again this week, I'm here with my family and we have personal connection to the work. I turn on the news, and again this week, I don't watch the news all the time. I'm talking about my local Channel 3. Again, a woman suffocated her baby and ended her own life in her bed. Okay? Why? So, all of this can be prevented because we're talking about untreated depression and suicidal ideation. Our research is epidemiological, where we are looking at the extent of the problem. We're counting how many times this is happening, right? We have new research that's coming forward that's finding that Black and Asian women in our rural in Illinois, in rural and suburban areas, Asian and Black women are disproportionately reporting suicidal ideation at the birth of a child. Most clinicians' hearts are in the right place, right? We have people that are good at their job and people that are not so good at their job. That's everywhere. And I've heard dismissive comments like, well, they just don't want to be here, so they're going to mark that. If anyone's reporting suicidal ideation, it's a crisis, right? So we need to start looking at those preventable deaths. How do we identify them? How do we provide the support, follow-up resources to those families who are in need, okay? So as a public health approach, we can screen women. That's where a lot of our work is. We can screen women. I know, Dr. Baker, you have a culture responsive screen. We can ask a simple set of questions, the patient questionnaire 9, it's patient health questionnaire. It's 9 questions: loss of interest, sleep, appetite. Yes, these things are wild during pregnancy and childbirth. There's questions about, have you thought about harming yourself? Okay, ending your life, thoughts of death or harming others. Red flag, how do we provide support before we send that family home with a new infant? Okay, so soapbox, I know I'm coming at you a lot. The work is emotional. There's a personal connection years after doing this work.
Yes.
Screening. My state, Illinois, was the 2nd state in the country to mandate screening. Even with a mandate, as great as we are with a mandate, people don't know how to screen, when to screen, which tool to use, and what to do when it's positive. Screening. Screen often. Episodes are episodic. They happen, they come, they go. Screen often. So more states need to come on board with public policy mandates to screen during pregnancy. We're always saying during pregnancy, before they go home, and in the postpartum. If we're screening women, does it work? So a lot of our work now works with patients to learn the effectiveness of screening. We're learning how patients use that tool to communicate mental health needs in a physical healthcare setting. So we've been supported by PCORI. We love PCORI. They've helped so much. We're helping together to have patient-centered outcomes. Does screening work? How do patients use that during the perinatal period? And then last, as Representative Kelly said, Medicaid expansion. When a childbearing individual is pregnant, they're eligible for Medicaid, okay? Or we have income eligibility for Medicaid. Nearly half the babies in this country are born in clinic settings sponsored by Medicaid, okay? Few weeks after, we remove that resource or that support of Medicaid. So Medicaid expansion is needed more than ever before to extend in that perinatal window to support those women for the full postpartum period. That's 12 months. those are my only 3 solutions. I'm going to leave it there. I know we have a lot to cover in an hour, but thank you again for the opportunity to speak and just exchange with you all.
Thank you, Professor Karen. See, that's the passion that drives this work. Like, you got to have it in this space to continue, one, to impact those who need it, and then impact the system at a larger scale. Like, thank you. Thank you. I appreciate that, because this work is personal. You'll learn, you should see it over time, but you'll learn over time in engagement that this work becomes personal, because it's attached to real life people. And so I'm gonna pass it over to Dr. Pepper. As someone who works directly with postpartum women, what are your thoughts as to how we can work together to bridge the gaps that currently exist for Black mothers in maternal mental health?
Yeah, I had a whole plan on what I was going to talk about. And then Dr. Karen came with it, and really, I want to elaborate a little bit on what she said, because I sat on the maternal mortality committee for maternal suicide in California. And so just like, you and many others, we spent months and months and months reading through the cases of women who took their life during pregnancy and postpartum. And the preventability of it was like, it was insane. It was like, as we're all reading it, we got social workers there, we have mostly, physicians and OBs, but all of us are like, especially on the mental health, like those that have worked in community mental health. I mean, I've worked like at the ground level of, the DV shelters and the homeless shelters and in the prison system, and just like with community centers, like how many times we've been able to intervene. But it took us being able to recognize that they actually had a serious mental health problem, especially in cases where they were sort of like on the fringes of things, right? So they're not engaging with people who are doing screening and assessment. And when they're engaging at their doctor's office, and especially at the pregnancy and postpartum period, there's the bias around not wanting to be around someone who is emotionally unstable, right? And not knowing what to do with that, because medical providers are not typically really well trained in mental health. And it's like, okay, well, let's refer you to social worker. Or, well, let's see if we can get some case management. Case management for what? Does the case manager know what to do when someone is imminently suicidal? And then how to, many times they might, but we have such a gap and a really poor connection between the actual resource, like if you are feeling like you want to take your life, or you're having intrusive thoughts, or you just really feel like, oh, I just can't deal. I can't deal. And that's like how people are describing it, right? Like, I'm stressed out. I'm all the way stressed out. And it's like, what does that even mean to a provider, right? When they're screening using terms, even as much as I love the PHQ-9, which you mentioned, as much as I love the Edinburgh but I oftentimes spend time with clinicians trying to help them explain those questions in a way that people would actually hear and receive and actually answer in a very practical way, but also like the gap in the way that people are communicating, not just like language, and of course language is its own thing, but if you ask, the average Black woman, do you feel like life is hopeless? Is everything hopeless? The term hopeless, especially for like such a faith-based community, like it may not align. They may say, well, no, there's always hope. I mean, there's hope. My ancestors were slaves and my grandmother was poor. I mean, sure, there's hope. But if you ask, like, do you feel like you're going to get through tomorrow? Like, do you feel like you're going to, like, do you feel like you're going to be taken over? Like, and it's very like community based. It's very, regional, right? I grew up in the East Coast, but I live in California now. The way that I communicate to people and to my family and to, when I'm in certain environments versus others, there's a distinction in the way that we talk about, like, what does it mean to be undone, or my nerves or my stress level, right? And so there's such a need, and this is why I advocate so much for Black women-led and Black and community, whoever the community is, like they need to have their own people, well-trained. We need funding for training, for full educational programs. And we have, certain aspects of American education where you can receive a full scholarship for certain things, and not for these really necessary, important levels of being able to be trained at a human engagement level, and to bring people from communities that really need the reflection of their own community in the services. Because we also have a historical concern and traumas around the way that we've been treated in medical care and in mental health care. I mean, as much as, there's a lot of hating on medical folks in the healthcare world, the mental health world got some interesting history. I mean, remember, like there was a diagnosis for running from slavery that was a part of the mental health perspective. There's so many aspects of diagnosis that have been gender-based and totally based on patriarchal and dominant cultural paradigms that have had to be shifted over time. And so that's not a safe space. Like, Child Protective Services and mental health typically go aligned. And so you go there and then they tell them, oh, she's unstable. Maybe they're going to send a social worker. Now you're going to get your kids taken away. Like, the worlds that we're also inviting people into, which we want more funding for, which are the public health systems that we have, are also the same systems that have oppressed our people, right? And so it's a very interesting, challenging, dynamic situation that we really have to navigate, that only we can navigate. You know what I mean? Like, only we know what our communities need, how they need to hear it, who needs to bring it in a way that's trustful. We have so much rigidity. There's so much rigidity in county programs and state programs and federal mandates. And it's, hey, Joanne. It's as much as we get excited about funding and opportunities, we also all sit back like, we know we're going to have to fight to get this to the ground. We know we're going to have to fight for the community to actually receive.
You're on mute.
You muted yourself. Okay, sorry.
That's when it's good.
Okay, I was going to say, I don't know where I left off, but we know that we're going to have to fight, even if we get funding, for the fact that we're going to be able to provide those services, right? That somebody else isn't going to come in and say, oh, well, I'm going to take these services to support the Black community. And again, like, without the cultural competency, without the relevance, without the buy-in, without the trust. So, as much as we really advocate for all of these solutions, we have to advocate for them really coming from and by and led by and strategized by the community, because nothing else has worked, right? If you look at our individual programs, our community-based programs that are just like, people got fed up, they're tired of figuring out what the government and the grants and so they're just going to go and start a little thing in the corner at the church. These things are highly functional. These things are I'm talking about, like, when I've worked at community centers and the people that we've been able to help, we're able to find housing, because you guys, so this is where I bring to, like, the community-based doula part, which is the part that I'm so passionate about as a doula, but also as a coordinator and like a networker and trying to help everybody get their community-based doula programs together. Because you have women from within a community who are trained to understand the needs of how to support pregnant, birthing, and postpartum individuals that are coming from the community. So they're also centering the importance of it being culturally relevant, because these are their sisters, their cousins, their mothers, right? We don't have to keep, I do a lot of training for a lot of people on cultural competency and implicit bias, and it's so important. And there are so many people who will serve the community, and everybody needs training, but there's a certain level of really having to push really far past, like, the veil and the lifetime of being raised to believe that Black women are angry and the resistance. And there's a lot of work that goes in to training people who do not have sort of like, they're starting at a one-on-one level and we are all at 401 level to deal with our own community, right? And so there's a leveraging that you can do when you're working directly with community. It doesn't mean just because they're Black, they're gonna not have some of the soup of racism and internalized racism that everyone else has, but there is a lot more leveraging and a lot more connection, the networks that they have. They know the local chiropractors and they go to the churches and they know the farmers markets. And this is the kind of thing that we need, the culture shift. And we talk about this a lot in BMMA, for it to move from like a public health and a research conversation, and those of us on the maternal mortality committees, and to like the local Black woman who's pregnant, knowing exactly where to go to be supported, feeling like, this is my sister, I don't have to be afraid, there's no barrier there. Like, I'm just gonna go down and talk to so-and-so, and we're gonna talk about mental health, and then she's gonna tell me where I can get my hair products for my kids, and then we're gonna go to the park and have the barbecue. Like, all of that stuff happens, right? When we get together, all of this happens. And then, the doctors are there too. We're also researchers. We're also public health professionals, right? It doesn't mean that being in a community also means you're outside of professional services. And that's a mentality that the dominant culture has about like the community versus like, we're the community. Like, I claim that we are part of this community, right? And so, yeah, those are my recommendations. We need more of us to be doing this work, and we need to give the money to us, and we need to trust us, even when other systems are in place that are diverse and they're run by multiple people, to really center bringing in people from the community to do this work. And I've seen it. I worked in the Native American community for many years, and when I started in my psychology practice, and there are systems in place where people believe that the community should do things for themselves, that they have to be on every panel. There's protections for child protective services for Indigenous communities because of the history that says you can't just remove an Indigenous child from a family without a whole slew of resistance from from the actual judges and lawyers. There are protections that are in place, and these are things that the African American community doesn't have in the same way, and there are models for it. So we just need to, you know, kind of push the envelope a little bit. And I'll pause. Thank you, Kay.
I can have you go on forever, but we only got an hour.
No,
that's our connection.
One reaction?
Yes.
One reaction, one point, because I know we have several researchers and trainees and future clinicians on here. I want to say to Dr. Peppa's point, it's a both and, okay? So all your comments, again, the personal is professional, are spot on. This does not mean that majority providers cannot serve minority women, or that it would be inappropriate to talk about mental health with a Black woman who might express signs of mood disorder, because maybe she'd be more comfortable with a Black provider. And I know, Dr. Joy, you have a lot to say about Hippocratic Oath and do no harm, but there's a both and. So there's one, it's the interpersonal level of cultural knowing and just being and just be a person, okay, instead of an other. Mm-hmm. That's part of it. But it doesn't mean that we can see only Black providers, right? So
Absolutely.
There's starting that the patient is a human and bringing your Hippocratic Oath and that approach. And then there's also the bonus.
Yeah. Agreed. And so
there's that bonus of having the nuanced understanding of health and being.
Yeah, so, agreed. Yeah. And so that's a perfect entry to talking and asking Dr. Career Perry, as an OBGYN, what do you see as the right now solution to bridging gaps in maternal mental health for Black mothers?
Hey y'all, I'm so happy to be with y'all. I love all y'all so much. So yes, the OBs are not built for it. So first we have to get out of the way. It's not part of our training or our our best asset and our best role is to understand our limitation when it comes to mental health, that we can use our power and our privilege to help build out a system around us. So to help support the shades of blues, to help support the research of Karen and Dr. Tab and Dr. Pepper, right? To help support people who are actually really working on mental health services, and to build and to bridge and to use that. Yes, we do see patients more than most people. And yes, we do have access to people who need service, but that doesn't mean we're the right people to provide that service. And I think that's where we keep getting lost in this conversation. People keep saying, well, everybody sees their OB. Yes, they do. But that doesn't mean we should be the ones doing anything about any kind of mental health. So we'll start doing little webinars or doing classes to learn about mental health. And that is not really, we're creeping outside of our real level of expertise and our real role. And what we really should be doing is supporting the folks who actually, that's their skill, like that's what they do. How do we help support and build up the capacity of everyone around us to support the people that we serve and take care of, and not try to colonize another field and act like we can do something about perinatal mood disorder, because we can't, we don't know what we're doing. So that's what I worry about as people keep talking about more and more that we need to build out this maternal mental health work, that I try to keep my colleagues at bay from acting as if it's something else that we're gonna take over and fix for people. What we have to do is sit back and listen, and then provide support for the people who actually do that work. So I don't know what else y'all been talking about, but that's my honest opinion.
Now, we just been talking. This is a conversation. We all know and love each other, so it just kind of had this flow. But you know, I had my technical question to ask you, which typically just leads us into like the Q&A, because it's blowing up over here. People have questions. But before we move into that, I just want to say, in regards to what you said, Dr. Career Perry, that I'm trying to refrain from calling you Joy.
I've been running from that a long time. When I hear Dr. Career, I'm looking for my daddy. That's who that was my whole life. Like,
is that as an OBGYN that you can make that statement that you know that this is not something that you can focus on. Like, this is not the lane. I saw in the chat pop up real quickly is that pediatricians are having that same issue. So I think full circle, like we're all struggling to say who should do the screening, who should do it, who should do it, who should do it. Somebody
I saw in the chat something about doctors doing the screening. I don't know that someone in our office, yes. But we've found that people prefer near peers. I mean, that's the data that I've seen. I don't know if you want us to be the one asking you those kind of things. So I'm here to learn. So if you tell me that that's not correct, I'm here for that. But what I've read so far is that it's not even our role to do that. Not me as the OBGYN, right? Like, that should be a part of my clinical practice. I should have social workers there. I should have people there to support, but it's not I physically. That's the thing. Like, the way that colonization works and the way that white supremacy works, OBGYNs are seen as we have to do all the things. And so if you make it a thing that it's just our responsibility, it's never it will be done incorrectly, and it won't be done in the way that the patient's needs are met.
But I think that's the whole issue too, is like, we have this attempt to want to standardize something, but the way that it actually is delivered isn't standardized, right? So some clinics, like in California, we have CPSP, and we have these opportunities for providers to be connected with social workers and mental health as a part of their practice. And in a lot of settings, people are just going to the OB straight. There's no other softer side of the world people. And so who will then do it? Who catches them? And so it's this issue, even when we did the suicide sort of interventions, like, where could there have been an intervention? The two places that the women went were to the OB and to the pediatrician. And the pediatrician even more, because they may never go back to OB, but they're going to go take the baby to the doctor. And so then it was like, well, that's the only place we know they will go, so it has to happen there. But does it have to be the OB and the pediatrician? No, maybe not. I mean, I need you to do the thing, like, to do whatever assessments, make sure somebody's not hemorrhaging, like, but then we'd have to say you have to have people in your office. You have to actually have a real, every time you're there, you have to have people, not just you can call later and refer to, because you miss that warm handoff and that connection and saying, oh, okay, well, Martha's here. She's going to come in and talk to you because I noticed that you marked some things in the entry that said that you were having some, concerns. And that's, sort of like, I think what you're saying is a great point, like, who does it? But also then we have to go a step further and say, then the OBs have to have a system. They actually have to have a whole person care model. And if they don't, we're in trouble. Yeah.
Can I offer a policy solution that's like right on point to where everyone's going with this? Because I love it, Dr. Parker. You said pediatricians. The mommy who's struggling with the most intense episode, okay? She's not eating. Is not missing that well baby visit. She's going. She's there, right? You take it to the pediatrician's office. It's not my patient. I definitely didn't train for this, right? If we're talking about training of providers. So Dr. Nancy Byatt, she's at University of Massachusetts, phenomenal. She has this model called MCPAP for Moms. So MCPAP was the state of Massachusetts approach to reallocate some child welfare dollars to provide psychiatric consultation, okay? So you're thinking state level mental health provisions, child welfare dollars, and they found a tremendous cost savings, right? Or return on investment. If you invest a little bit providing a telephone consultation support, get those kids the mental health support they need, we're gonna save some money. They expanded it, they call it MCPAP for Moms. Amazing. They found that every case of untreated depression was costing Medicaid an extra $22,500 from associated complications. So providing a support, a phone number for providers to call to get to a psychiatrist to help walk them through a treatment plan and support cost the state $850,000 total, okay? So huge cost savings, and that is called the collaborative care model, where you use a psychiatric consultant, social work care managers, psychologists, care managers, like licensed psychologists, to provide support to other providers. And it costs the state $850,000 total. And think how many mamas are getting support they wouldn't get otherwise.
Absolutely.
We can't push everything to peds.
No, but it's a good point. And even just to, so that people know, Postpartum Support International has a line with psychiatrists to be able to consult with doctors. And one of the things that I've pushed to do is in all the community-based doula programs and in all the doula trainings that I do, making sure that they know, look, if your clients have mental health stuff or if anything comes up, make sure that they know that this is a number that they can tell their provider, because it's odd. This exists. It's amazing. Providers don't necessarily know about it, right? And so then it's not used. You almost have to self-advocate that I have this situation and you told me to come on my meds, but I heard that that's not a good idea, that I should actually have a consult with somebody that knows about how to manage medications during pregnancy. Can you consult with this thing? It's free. Here's the number. As crazy as that sounds, that's the level of self-advocacy at the community level has to be done to really mitigate some of these. So I think that's a great point. And for those that, didn't know, it's out there and on their website.
Thank you so much for bringing that up, Dr. Pepper, because, sometimes I always say Dr. Pepper is my, the twin that I didn't know that I had. We had the same birthday. But speaking about community level and community-based providers is so important, and they are so important to this conversation. And even talking and thinking about this even from a policy perspective, and how we need to have policies at the federal and state level that supports community-based care. I'm even thinking about in particular our midwives and our doulas, who also are a form of support for a lot of the very Black women that we're talking about, who are rightfully so, not entrusting a lot of institutions. And so the more that we can even expand when we talk about providers in this sense of who can be helping to provide maternal mental health services, we also need to expand when we're talking about those type of providers to be inclusive of doulas, midwives, and other nurse practitioners, all these folks who operate at the community-based level, especially during this time of COVID-19, where we're seeing an uptick of certain hospitals in certain jurisdictions sending pregnant women and women in the postpartum period to a birth center, or sending out these referrals. And so so understanding these different types of scales and understanding the importance of, asking these important questions that we were just talking about just now, I think is also important to expand that to other providers, and that those providers such as midwives and doulas are properly reimbursed, and that Medicaid recognizes their services, even in the area of maternal mental health. And lastly, it is important, and I have to do this just due as a public health professional and somebody who believes in Black women researchers in this field, I have to uplift Dr. Fleta Mash Jackson and a lot of the work that she has been doing over the decades, and how even her work in terms of developing one of the culturally congruent stress scales, whereby they did a lot of research with Black women in particular for over 10, 15 years, develop culturally congruent types of questions and a scale to help start those conversations in a way that will engage folks in our communities around mental health. And then we also have, I would say, some new organizations that are really stepping up in the forefront of just Black mental health in general. I think about Beam and a lot of the work that they're doing. And so these are some community-based resources, and of course, Shades of Blue Project, community-based resources that a lot of people, wherever you fall in the spectrum of as a healthcare provider, or a public health practitioner, or a community-based health worker, that you can pull from in terms of providing the necessary referrals, questions, and just resources to your clientele.
So yeah, look, I told y'all this is gonna be a candid conversation. And so as I go through the Q&A, a lot of them are just, giving some general, this is great, the conversation is good. One of the questions asks, wait a minute. are there peer support models built with OB-GYN practices that we can look to start replicating those initiatives locally? If there are, I am not aware.
There are. I just, I guess to Angela's point and to everybody's point, I just don't want to center this conversation around OBGYN. So I guess I just,
Right.
I struggle with, because we take up so much space and I just think creating a system built around kind of OBGYN is not what we would want to do in building up something for Black birthing people. So yes, there have been some pilots, there have been some programs. When I think about in my own practice, I would consider the work that we did with the National Healthy Start, with Healthy Start folks. They always there were peer support, mental health services. And so many OBGYNs across the country, they're familiar with Healthy Start as a referral source, as a community partner, as a place for their patients to receive care. I would honestly say they're probably more familiar with that than they are with some of these organizations that you all have been mentioning today, like the phone number and the phone line. So that gets back to, if we're gonna build a system for mental health, and we really need to work with the people in the community and where they are, and then build a collaboration, a community network, including doulas, midwives, birth workers, researchers, and also OBGYNs, to make sure that the perinatal moods is a localized, on the ground system that's built for the needs of that community. I just, coming from high on high and then creating a system has not worked out for us ever. And so it just worries me that that be the strategy going forward for our, now that we recognize that so much around our maternal mortality is mental health related. So it's getting a lot of attention. And then we are not at the table a lot of times in these conversations. So the we, I mean, is now I'm making myself a community person, because I'm community too. That's Dr. Pepper said so. So we don't get to be in the meetings around policy. And so I'm afraid that the people who actually have lobbyists and have access to policymakers are going to get this resource for perinatal mood disorders, and then the real folks on the ground who've been doing the work for a long time are not.
I am in
Ditto.
total agreement.
It worries me.
Yes.
But I'm going to put in something in the chat just for those that are interested in looking at a model that is sort of, holistic in some ways and trying to bring in providers. And the California CPSP model is pretty helpful. That stands for Comprehensive Perinatal Services, and basically is a way to help providers, like, medical providers, have social work, mental health, and that it must be all, they have to figure out a plan to make all of that accessible to each client. And so certain people, especially particularly Medi-Cal here, Medicaid for the rest of the world, providers are required to have that.
And that model is something that people have been trying to replicate across the country for a long time. Y'all have had that in California for like 20 years. Like it's not a new thing.
Yeah,
and
but it's developed in different ways. But
But I'm just saying that other states are trying to figure it out, and they have not able to even do what you all have been doing for 20 years.
Yeah, because but really, if you ask us, we're like, bring it to the community. We will handle it, right? Like that's what I would say to that, because there are already community-based programs, like Angela said, that are about creating parenting programs and doing resources. And we have something like these perinatal programs for Black women that do baby showers and the breastfeeding groups. And this is the place where you have mass amounts of people from the community who are there, and if they needed something, this is a place where that funding should be, so that they could have the resource right there where they're going, right? And so yes, they have to go to the pediatrician, and they have to go to the OB, and we can sort of public health, we have records of it, so people feel more comfortable because they can track it. But we go to our barbershops and our hair salons, and we used to, we're in our community, and we have systems that could be leveraged to put money and funding in, and it would be way more accepted and I think more effective, because it's not like there's another place to go. You know what I mean? Like, you're going to go right back to the community.
I agree.
Dr. Baker, go ahead.
No, I agree, because when I've talked about this whole power shift that needs to happen, this determinant of power, that in itself, like, who is getting funded continuously who's over-resourced. If we use the term under-resourced, and then that means there are folks that are over-resourced.
Who's hoarding? Who's hoarding?
Right. And so as I sit, as Kay and I sit in Texas, where we would love to do that model in California, but honey, so like how, where, I think I brought these questions, like the transformation, like we are literally ready, but like, what is that? What does that look like? What should we be saying? What should we be thinking about?
Yeah.
Yeah.
Well, y'all, I knew this hour was gonna go by quickly, even though my nerves was on edge about like it was gonna drag out. But here we are, in the last 5 minutes of this conversation, and we're gonna keep this going because Black Maternal Mental Health Week starts Sunday. We got a whole week to continue these conversations, even beyond Black Maternal Mental Health Week. These conversations will continue. Thank you. I truly appreciate everybody's insight today, and also ensuring that Black mothers and their voices are heard. Like this is why I put all of us together, because I know that you all genuinely care about making sure that our Black mamas are heard. As I moderated today, I thought it was only right that I share like a little bit of who I am and why this works and why this will continue to be. I would like to say that so many women out there have horror stories about their birthing experience, and I happen to be one of them. I'm here today because of my traumatic birth story and the deadly outcome of delivering a stillborn child. Along with that was my lack of maternal mental health treatment, even when I sought help. Because of that, this is why I do this work, so that my voice can be used to help others heal, also help those women who will never publicly share their stories, but their stories must be told, and that they feel like their birth story matters no matter the outcome. We must continue this conversation. We also must continue to address racial disparities in maternal mental health, the screening, the treatment, by recognizing that one, the disparities exist, and that we have to start working with organizations that are currently tackling these issues. I'm not the only one. We must educate and raise awareness of the prevalence and the effects of maternal mental health disorders, specifically amongst Black women. As Representative Kelly stated in the beginning of today's conversation, the Helping Moms Act expanded Medicaid coverage to new moms during the postpartum period for 1 year truly could be the difference between life and death for our mothers and their babies. This is something we can all work towards now to make this all different. Of course, I want to thank all of my coordinating partners, my fabulous colleagues, round of applause, for helping us make today's event a reality. I want to thank all of you for joining us as we look forward to continuing to make shift happen in maternal mental health for Black mothers. Again, I thank you all. We're going to stay on time, y'all. We're going to break some of these. It's 2:58. I think that we have given enough of people to continue this conversation and to jump into action. Like that's what we need now. We know what these issues are. Now we need to take some of these action steps that were given today that will continue to be given over time and implement them. That's where we are. We're in implementation stage, and a lot of the suggestions today are implementation ready. Again, I appreciate you all for joining us. I appreciate and love you all. And I look forward to y'all joining us for Black Maternal Mental Health Week. All right, y'all. Bye.
Thank y'all.
Thank you.
Thank you.
Bye-bye.
Love you, Kay. Bye.